being on the rotation had increased the awareness of the economics of healthcare and awareness of cost. So the authors concluded that global surgical rotations can be conducted in an organised manner in a large academic institution and with clear benefits to the trainees that participate. They concluded that global surgical rotations can have a pivotal effect on participants that extend way beyond the residency in terms of altering the perceptions on costs and commitments to domestic and underserved population and to global surgery in general. And they concluded that global surgical rotations are valid methods for increasing interest and future involvement in international healthcare efforts. So I thought there's a few points coming from this paper. First of all, it's a very small study size, only 17. However, only 17 people have ever been on the rotation, so you can't really expand that population more. They're just evaluating their own programme. But taking that into account, I actually think they've made quite a poor choice in methodology, because they've used questionnaires rather than kind of focus groups or semi-structured interviews. And the main benefit, to my mind, of using questionnaires is they're easy to use for a large number of people, but you actually gather quite superficial data. You know, how meaningful is it to say that somebody's interest has gone from 66 out of 100 to 84 out of 100? You know, what does that even mean? And going on a global surgical rotation, you think, is such a complicated, multifactorial experience. I don't think they've collected very meaningful responses. So if you had done this and had semi-structured interviews with them instead, so rather than going in having determined already what range of answers that you can have, and just gone in and asked people what their experience was, and then use that and a sort of grounded theory approach, you would have a, and then so what you'd do, you'd do your semi-structured interviews, and then you'd transcribe them all, and then develop a coding framework, and then use that coding framework to build up themes, and that would be your results. If they'd done that, you'd have a much better idea of how this rotation had impacted on people's choice and what had happened to them, and what elements of it that they found useful, what elements they didn't. And then, you know, there's also some minor issues with actually the questionnaires. So, for example, they say that the rotation was very satisfactory, but, you know, they don't give us the mean satisfaction for other rotations. So it's difficult to compare whether this rotation was, you know, particularly well regarded or average, or actually people had better experience on other rotations. And also there's the issue of recall bias, because they're asking people to retrospectively score their pre-residency and post-rotation intention on the same questionnaire, you know. But the other major issue that I have with this paper is, for a paper that mentioned partnership a lot, it's incredibly ironic that this is a completely one-sided evaluation of the programme. So you're expected to take very positive description of the programme impact at face value. So they say, oh, the visiting trainees worked side by side with the host residents in patient care, which fosters academic exchange, training, research collaboration between the respective group of young surgeons. And this rotation was designed to preserve and promote the training of the host residents, ensuring that the visiting residents don't compete for cases or clinical experience. Well, that may well be the case, but you could also have a situation where actually for the Kenyan hospital hosting a bunch of American residents for only 4 weeks, that, you know, if you look at how many of them had actually been outside the US, most of them hadn't left their own country before. So they come, they can't speak the local language, they've never been abroad before, they've never worked in a developing country before, and they're only there for 4 weeks. And do we even know if they can't speak the local language? Can you mute your microphone?
Just until discussing.
Till the discussion. So we don't know what impact this study had on the Kenyan trainees. because they never asked. So in terms of things that I thought would be interesting to discuss as a group, I thought we could have a chat about what role postgraduate training programs have in turning interested medical students into consultants that are actively engaged in global surgery. Because I looked at some statistics, and 90% of UK medical students go abroad for their elective, and 40% of them actually go to developing countries. So, and when you look at like global health related integrated degrees and postgrad degrees, there's loads of really interesting engaged medical students. But actually, it's only a small proportion of people that go on to work in a developing country or be, formally engaged in global health things as trainees and consultants. So I thought we could have a chat about how we think we can do that. I also thought that it would be interesting to talk about what a good partnership between an academic institution and a lower middle income institution would be. And what do we think about length of rotation, trainee roles? And also, I just thought, can I have a broader chat about what we thought a global surgery career pathway should be like? How do you train a global surgeon? So over to you. What do you think? So you can put your mics back on now.
Can I make a comment? It's Robert from Oxford. I'm a plastic surgeon. That was a great presentation, very clear presentation of the paper. Thank you. And I agree with your critique of the paper. The things that you bring up are actually very valid. I was just going to make one comment about, at the beginning,
yep,
you described that 18% of the residents had shown an interest in having a global health career.
Yes.
In the initial questionnaire. And then you said that about 21% went on to the global health rotation.
Yes.
So the question is it the same, because that's roughly the same number, is it the same group of people who actually went on to do the rotation? Are those that already said they wanted to have global health in their career?
So they don't tell us.
Because in that case, actually, the rotations have made no difference to their lives. They were the same 18% who wanted had an inclination towards this anyway.
Yeah. It's also interesting that the percentage of people that haven't been abroad that went on the global surgery program is actually higher than the percentage in the general group. So the people that went on the global surgery rotation are actually less well-traveled than the peers in general.
Right.
So,
but as you said, you do wonder how they can be, because you said that they wanted them to have more integral role. Yeah. They go, you can't, if you've never been away, you've never been to this place, you can't in 4 weeks suddenly be, treating and seeing patients and becoming part of a team.
Yeah, no, it's ridiculous. You wouldn't expect a Kenyan graduate to land in a major teaching hospital here and just straight away in 4 weeks being integral part of the team. So why should it go the other way?
Yes, exactly. And I think in terms of your question about having a discussion about the fact that only a small number of people in the UK end up doing global health or global surgery related work, despite the fact that a large number of us go on medical electives, I think that is partly because of the way our careers are structured in the UK. When medical student electives are built into our medical curriculum, so you can go away. Once you become a trainee, these are not built into your training program. And we're trying to set up a clinical fellowship here, but the question is who's going to fund it? Yeah. We can't convince our trust to pay for one of our registrars to disappear off for 4 weeks. The trust just goes, that's not in our interest. So that's one thing. During your training, it's not facilitated. But once you become a consultant, again, it's the same issue. We just don't have a career structure set out yet that allows consultants to be involved with global health as well as their normal NHS work. And until we've got that sorted, we're not going to have many people who can engage with global health work.
Precisely, because I don't think it's particularly valued at the moment, in a way.
Yeah, exactly. It's not that people aren't interested, it's just practically not possible.
And it's not valued in an academic sense. So I feel it's valued in terms of it's a nice thing to do, and everybody is happy to collect money and whatever, but I don't think it's valued as a genuine career pathway, and the research shares the same merit as basic science research or whatever.
Yeah, I completely agree. And I have this sense, we've got a pretty big group here with a lot of research coming out, and we had some basic scientists who, anaesthetists who do basic science work telling us the other day, well, it's not really real science, is it? They actually said that.
Mm.
And so you're absolutely right. People just don't value it. Mm. Both in the clinical sense, in terms of trust, valuing our time and feeling responsible towards global health issues, but also from the academic side. So we've kind of got this struggle between both sides of how do we set out these career structures for all of us who are interested. We do need to start making those there, otherwise we're going to have this struggle year after year.
Can I say something?
Yes. Please do, Joseph. Good to see you.
Thank you very much. You can see me in Rwanda.
Yeah,
okay.
Good to see you.
Yeah. Okay. Me, I can give a comment about that. I think the global surgery, there is a partnership, bilateral partnership or benefit, and sometimes we don't see it as a bilateral benefit, but seeing as some people coming from high-income countries coming also to only to help, but they also, on my point of view, everyone is gaining from that. So yes. There is someone comes with theories and good settings and come to work in the settings where there is nothing, but also there is much exposure. I think that is a benefit, and when it comes for like a rotation, someone comes to rotation but not come back when a consultant. Also, I can see as something somehow wrong, because you started with on patient, if I can say, but when it comes to somehow to give back, you don't come. For me, what I can suggest is that if you benefited from your training from global surgery, I think you can continue. I know that what you are saying is somehow difficult to release a consultant to come to work in Rwanda or in Africa, letting people, the patient in UK or elsewhere. I think that's difficult, but I think it can be advocated. That is my comment.
Thank you.
Can I ask a question on behalf of King's? So, unfortunately, King's are having trouble.
Can you hear us now?
Oh, we can hear you.
Yeah. There's an echo. Can you hear us now?
Yes.
Yes. Oh, you can hear us?
Yes.
Okay. Maybe Andy, you need to come and try it. There's an echo without what Andy was saying. So maybe if he's a bit closer or something. So I can hear. Oh no.
Can you hear me now?
Yes, yes.
Great. So I just wanted to also, it was a good presentation and a good critique. I just wonder if we could move the conversation back to what may be useful research questions. Because I mean, if this was done again, or if we were to set out and do a piece of research to evaluate a program from the UK, what would be the key research questions? And I'm sure a qualitative research approach is the right one. You can go much deeper and learn a lot from even a small number of interviews. And I think for me, we need to understand how to prepare trainees for these sort of placements. So I think there'll be some, if you're doing a semi-structured interview, I think that would need to address questions about preparation, as well as support on this time abroad. We need to ask, well, what is the minimum amount of time? I would say 4 weeks is ridiculously short. A minimum of 6 months will be necessary to really do anything of any value for the individual. We certainly need to ask questions about how we can possibly work with a real spirit of development, as been pointed out by Joseph, and what's the sort of work that trainees should be engaged in, aside from clinical, there's quality improvement work, there's research work, there's some educational work they could do. So I think there's a whole lot of questions that we might want to brainstorm before we redid a study like this, because I think fundamentally this doesn't tell me anything new. I don't think it tells us anything new I mean, it's useful that they've reported it. They've done this program, and all credits to them for doing it. But I don't think it tells us anything. And I don't think it feeds usefully into any new plans we might have in the UK for trainee placements in an LMIC setting. And I think the gold standard should be to do things with a real spirit of co-development. Yeah. So we've really got to think hard about the perspectives of our LMIC partners. We've got to think hard about preparation, as I say, and reflection on back, and what the trainee brings back, but also what the wider NHS gains from this sort of initiative. So I think, that would be my view on next steps as well.
And that's really useful to hear. Just wanted to ask you a quick question. Have you made any developments at your King's End in terms of convincing the trust that it's of value to the trust to allow clinicians?
Okay, so we've been involved in this work for a long time, but actually in recent times we've sort of refreshed our efforts to engage. We've just done a 10-year review of our partnership, so we've got a 10-year strategy document which we're now sharing, and all the NHS chairs and chief executives of our 3 NHS organisations have brought into our health partnership work. And we now have a governance structure where every NHS organisations, as well as the KCL, are involved in strategic decisions about our partnerships. So broadly speaking, there is a lot of engagement. And at the moment, we're just about to launch, well, probably next April, what we call a King's Health Partners volunteering scheme, which is a new, which can be a properly branded, properly sort of celebrated way of not just trainees, but consultants and biomedical engineers and anyone in these 3 trusts engaging in our partnerships through a sort of volunteering and secondments. And so that's a new push, if you like, to try and get the engagement. And we certainly got a high level engagement. And yeah, so more on that soon, I hope.
That's great.
Yeah.
Could we have a look at your 10-year partnership document? Is that widely available?
Yeah, absolutely. I can send it to you. And in fact, one of the things that we've modelled it on is Cambridge Global Health Partnerships. Because in Cambridge, Adam Brooks Abroad have really made a lot of progress in their work in various countries, Burma, and Botswana, other countries. And they have a lot of endorsement from their own trust. And in fact, when the trust was visited, in formal visits, quality improvement visits, this is mentioned now. That's something that so I think there's quite a lot going on. We can certainly share that with you.
John, Andy, can I ask you? You were very reasonably making the point there that this doesn't really give us any additional new information. So, what are the key bits of information we want? Obviously, some research is performed almost predominantly for advocacy reasons. So, if we wanted to influence training in the UK, we would certainly need to be producing compelling evidence of benefit. Is that the kind
of? So I think it slightly depends who you're aiming at. So I think if you're trying to convince NHS leaders, then what they, and I mean, I was speaking to a medical director about this morning, and she was incredibly enthusiastic. But when I asked her, what do you want these trainees to return with? What are the sort of skills you want, the attitudes you want? She talked about developing leaders. She talked about people being more resilient when they return. She talked about perhaps people valuing resources differently, and the way they order tests. Maybe they reflect a little bit more before they press the button. She talked about true multidisciplinary working. We play lip service to it, but I think true multidisciplinary working, which you can gain in the field, is something which you. So I think that's the sort of things they want to see evidence of. Yeah. Now, if you're talking to an academic training program, they probably want to see a different sort of evidence. They want to see evidence perhaps that's more clinical or more quality improvement or evidence of research capacity building for the individual. I think if we're trying to convince DFID or others to fund this sort of thing, we would primarily have to demonstrate benefit to our partners and impact in country. And so that's perhaps quite difficult for an individual trainee, but if that's part of a long-term partnership, then it's just a component part of benefit to an LMIC partner. The trainee, but also other things that the partnership is bringing to that LMIC partner. So I think it's slightly depending on the audience.
Thank you
Can
very
I
much.
ask a basic question, Anand here? Sorry, I came late, so maybe this was already addressed, but I did some work with the Askari Serpent program in the British military, and this was maybe 2-3 years ago. And so the Askari Serpents, provide primary care to low, middle-income countries. And one of the fundamental questions I asked them was, the way the Askari Serpents program functions is basically they're looking to provide training to the British military healthcare staff so that they can work in difficult environments. And so there was a clear benefit. They designed a program to deliver a clear benefit for the medical professions within the British military. But it almost struck me as almost sort of a colonialist model, in the sense that they were looking for the benefit for the British military, but they weren't actually asking the folks on the ground. There was just sort of a foregone conclusion and assumption that they were delivering value to the folks on the ground. So for these, again, sorry, I came late, so I didn't hear the beginning parts of the paper. I'm not familiar with the training programs that are done, but do you actually ask the folks on the ground in these resource poor settings what they need before you send the trainees out? So, I mean, the past few minutes we've been discussing what the benefits would be to the NHS. Are any benefits actually being delivered to the folks on the grounds in, say, Kenya, etc., the places where these trainees go? Do we have any indication that what we're doing on the ground over there is actually beneficial for them, or is it detrimental?
So, I think the point about how we measure is really important. So within our 10-year partnership document, the principal thing we look at is impact in country. So we have a whole set of key performance indicators to measure impact in country. But I think if you're really talking and you're serious about co-development and you're serious about equal partnerships and equal power sharing, and in the SDG area, recognizing that it's a global community we're in and we need to be working together, then it's perfectly legitimate to think about benefit to the UK in this case. But obviously, it's not just our benefit to the UK. It's within the context of predominantly the bias, if you like, being benefiting country. But I think it's fine to speak about benefit to us. I mean, when I'm in conversations with ministries of health or whatever, I'm unashamed in talking about what's in it for us, because I think that's a healthier way to come into a ship.
Thanks very much. Thanks very much, folks, for those comments. I'm just conscious that with us starting nearly half an hour late, I don't want to keep you outrageously late beyond our stated time of 8 o'clock. So although we're having a great discussion, and thank you for your comments, we'll move on to hear Emily. Can I check that you're seeing the first page of our slides, first aid management of paediatric burn and scald injuries?
Yes, we can see it. It's just a little bit off center, so we're missing the...
Shall we try and make it full screen in that? Would that work?
Yeah. Perfect. Great. Thank you.
Is that better?
Yeah.
You can see that well? Okay, great. So you should be able to just do left, right? It should work.
Okay. Yeah. I'm just meaning to make it big screen, full screen. Okay. Okay. Thanks, everyone. So yeah, as Stuart's already said, I'll just crack on. For anyone who saw the paper, so I'm a sort of person, I kind of need a deadline to make me actually get around to doing something. And Stuart said to me, here's your deadline. So it's very much a first draft that's out there. Thank you for taking the time to listen to me go through it. I'll quickly go through just a short presentation really of the main findings. And I guess I'm looking for advice with regards to how do you write up a mixed method study in about 3,000 words. I'm totally new to qualitative research. This is a study I did as part of my MPH this year at Glasgow Uni. So if anyone out there has been publishing with mixed methods, I'd really appreciate a bit of advice around how you can, I guess, get into that word count. So the background, I heard there was a plastic surgeon in the audience, and I'm sure a lot of you have heard about burn injuries if you've done work in low middle income countries. So 2008, the World Health Organization recognized that burn injuries had become a major public health issue, noting in its plan for burn prevention and care that over 95% of fatal burn injuries occur in low middle income countries. By far the majority of burn injuries in sub-Saharan Africa occur in children. And so about 10 years ago, I worked as a paediatric surgeon in Malawi. And I, basically witnessed that firsthand. Loads of our kids were just coming in with burns. So the major reason for this in Malawi is the use of ground level cooking stoves and also open fires for space heating. And as I'm sure you all know, appropriate first aid is described as cool running water for 20 minutes. And it has been shown to result in statistically significant reduction in pain, along with improved outcomes of quicker healing, reduced scarring, and decreased requirements for skin grafting. There is literature out there. So I did a review of the published literature relating specifically to first aid use for paediatric burn and scald injuries in sub-Saharan Africa, and it returned only 11 studies describing the type of first aid used at the time of injury. The largest number of patients were in Ghana and South Africa, and these circles represent sort of the number of patients in these studies. No studies were identified from Malawi. The commonest first aid treatments are water, egg, cooking oil, and butter. Regional variations are noted, such as the use of honey in Tanzania, engine or brake oil in Nigeria, and the use of animal dung in Eastern Europe, in Eastern region, sorry. The literature outside of Africa demonstrates that parental socioeconomic position and education levels are linked to a higher knowledge of first aid, but this relationship is a bit more complex in low middle income countries and therefore does need to be explored. The influence of cultural beliefs in traditional medicine practices was also evident, but none of the studies examined injury scenario factors as a possible influence of first aid choice. So I mentioned the background. When I returned from working there, I set up a burn prevention. I co-launched a burn prevention project out in Malawi, which we were funded by UK Aid, 2 3-year projects, and we collected prospective data on admissions to the unit, and then we used theatre development. We partnered with a Malawi NGO who do theatre development, and they presented back the scenarios of our 5 commonest injuries that we were seeing. So this is where sort of my background comes from. We were aware that even though Nancy County Arts were educating on the use of water as first aid use, we were still seeing lots of patients in the hospital who used other things. So I felt that it would be useful to do this as part of my dissertation. And the discussion we had just there in the previous paper was actually quite interesting, because this is the first time in 10 years of being involved in global health work that I was able to marry up actually doing this as part of my day job. So yeah, it was actually a joy for a year to be able to just study this in my day job hours, instead of having to try and cram it into all the extra time, the evenings. So the aims of the study were to identify, identify the first aid practices in paediatric burn injuries. The hospital that we are based at is the only burn unit in the southern region of Malawi. Initially, it was the only burn unit. There's since, I think it was about 2013, a second burn unit opened up in the central region. So I stuck to southern Malawi, and I was interested to determine whether there were patient factors or injury scenario factors which might influence the type of first aid used, and also to explore knowledge, attitude, practices after paediatric burn or scald injuries out in the villages. So this was a sequential explanatory mixed method study. So I started with looking at, so when I was out there, before I left, I set up a prospective database. One single nurse has kept that database going over the last 9 years. She interviews every patient who is admitted to the unit aged less than 17 years. Patients who die within 12 hours are not interviewed, and there's a specific pro forma that covers kind of all the demographics, injury, free text for how the injury occurred, outcomes, and what happened with the patient in hospital. So it's a really quite a thorough pro forma. And so I used this database to do the secondary analysis, looking specifically at the first aid at the time of injury. So this was when the patient's admitted to hospital, they're interviewed about what happened at the time of the injury with regard to first aid. I then followed on with the qualitative phase, which was semi-structured interviews using a purposeful sample, which for those to explain that, I specifically requested that people in the village who had witnessed a burn injury in a child would be the people that we'd be interviewing. I didn't want anyone that had a serious burn injury, as in that they had died after the injury. So it had to be a minor burn or scald injury. And it wasn't difficult to find because loads of people have burn and scald injuries. So recruitment wasn't difficult. And then I performed thematic analysis. Okay, so this is the quantitative results. There are 1,326 children in the database. It roughly equates to about 4 admissions per week. And the median age is 3 years. This all fits with what we know in the data. You know, the burn injuries are commoner under the age of 5. And the commonest cause of injury was hot liquid followed by open fire. So it fits with what we know in the literature. A third of children had no first aid applied at the time of injury. 1/3 had water applied, and about a fifth had egg applied. And you can see the other applications noted there. So using test association and logistic modelling, statistical significance was observed in 7 out of 15 variables. And interestingly, these were mainly injury scenario factors. So cause of injury or location of accident were found to have an effect on the type of first aid used at the time. And if I just go to this table, just shows the effects of these variables. So increased use of water was seen in injuries due to porridge, when the injury occurred in the living room versus outside, during the dry seasons. And an increase in use of first aid is seen in those whose parents had secondary education, but this didn't translate into increased use of water, but it actually translated into increased use of eggs and other materials. And what was also nice to see was that in areas where Nancy Canby Arts had performed, there was an increase in the use of water, but also other types of first aid, and less people used no first aid at all. So moving on to the thematic analysis of the interviews, 4 main themes were identified. And I don't have enough time to go through all of them, so I'm just going to give you a couple of examples that I thought it might be helpful to show how the qualitative findings help to explain some of the quantitative analysis. So firstly, I went into the study with the expectation that water wasn't used more often in first aid as there was a lack of availability, that it had a perceived high value, and therefore people would not want to waste water. So I was actually really surprised to find this wasn't the case at all. There were 2 boreholes in the village which served approximately 400 people. Everyone commented that water was freely available. But actually what was really surprising was that there was a real deeply held belief and fear around the use of water after burn injuries. There was a fear that it would cause skin to peel, that would make it turn into a wound, and therefore an open wound required them to go to hospital. And this was a really quite a deeply held belief. Except in the case of small porridge burns to the arm, where actually people did say using water was okay. And so it seems to be that size did have an effect as well. So a small wound, it was okay. If it was a small porridge burn, then using water was actually okay to use. But otherwise, the main aim for their treatment that they were trying to treat the injury for was to preserve the blister. So prevent a blister coming up and also preserve it when it does come up, stop it getting big and stop it bursting. They were the main aims of their treatment for first aid. Often eggs were used, they were readily to hand, and the availability theme, this was kind of like the final common pathway, and influenced the behaviour type of first aid used at the time of injury. So it was often what was to hand, and eggs were commonly to hand. But yet again, that conflicted because water was readily available, but they didn't want to use that. So eggs were very easily available. Eggs had been passed down through the generations. The intergenerational learning was really interesting. It was a very, very strong theme. Everyone learned from the mother. The mother had, there was a lot of trust in what the mother would say. And I think this linked to their role and responsibility within the community. It was very much the women's role to look after the children. And therefore what they said to use as first aid was held with sort of high regard. So the mothers passed it down that actually eggs should be used. And it was really interesting to see that kind of trust and that roles and responsibilities linking together with lots of things. And I'm aware I've got time pressure here. So I've just briefly touched on a few things. Key messages, injury scenario factors influence the type of first aid, and higher education levels don't translate into more appropriate first aid per se. Eggs and other traditional medicines are commonly used due to cultural beliefs around wound perception, and the role of water and first aid comprehension are more likely to be influencing factors for the use of water than its lack of availability. So my feelings were that we should be cognizant of the fact that public health messages should address underlying fears associated with burn wounds and provide clear education on the purpose for using appropriate first aid. And the design and delivery really needs to recognise the importance of intergenerational learning, so that we're not coming in with something different to, you know, what is being passed down, but trying to incorporate all of that into the messages and the way of delivering it. I thought it'd be really, really useful to look at people who currently use water, because there's a third of them use water, and I thought it'd be really interesting to actually interview these patients or guardians, because we might actually find additional facilitators to how we could then tell other people why they're using water. And I also think there's a real lack of scientific research exploring the effect of egg on burn wounds. And so to properly categorise that as either appropriate or inappropriate, I think we do need actual, you know, an actual scientific study that can look at that. So thank you very much. It was a bit of a whirlwind, but thanks for your time.
Thank you very much, Ellie. That was really fascinating, really interesting indeed. And we've got about 10 minutes left to discuss that. So does anyone want to jump in with a question or a comment for Emily? Robert, are you still there?
Yeah, I'm still here. No, I thought that's actually a really, really interesting study, and it's quite intriguing, this whole the cultural beliefs of what people use for burns. And burns wounds seem to be a particularly interesting wound where people start using all sorts of things that aren't used for a lot of other wounds. You know, as you found out with egg, but you know, we've had all sorts from toothpaste to eggs, and eggs seem to be a cross-cultural thing.
Yes.
In fact, we've had a lot of people with, when I worked in Birmingham, there were a lot of children who used to come with eggs in Birmingham on their wounds. So there is a kind of a cross-cultural, and this wasn't from a particularly African patients, they were kind of more from Asian patients in Birmingham.
Yeah.
But as you said, I'm not advocating the use of egg, but actually there are a lot of things that are used where we'd like to say don't use this, there's no evidence, but actually there's no evidence to say that egg isn't good.
Yeah, that's what frustrates me, I think, and that's what I felt really awkward about when I was interviewing these the people, because I was feeling that, you know, I don't know that egg's wrong to use, and actually it was quite good being in the researcher position, because I could actually, it wasn't my role to tell people, I was literally there to get information from them, and I made that clear from the start, because I wanted it to be clear that I wasn't there to tell them what to put on wounds. I just wanted to learn from them.
Yeah,
it was quite difficult. That was one of the difficulties I had, actually, was empowering them to feel that their opinion was useful, because none of them were educated, and so I've lost my train of thought. But one of the learning points for future is, I think focus groups would have worked better. I did semi-structured interviews, but actually I felt like it was an interrogation, and they were really quite uncomfortable. And actually, when there were 3 participants who spoke English, and together with the translator, they played off each other really well. and they were much more confident, and there was much more conversation facilitated. So for future, if anyone is thinking of doing this sort of work, I would recommend focus group discussion. That's the way I'd go as well myself.
I think, like you said, it is about, it is about really getting to the root of the problem of why people do what they're doing.
Yeah.
And really, it doesn't even matter what the outcome of the study is in terms of whether water's better or eggs better. You're not going to, until you actually address the reasons for the behaviour, you won't be able to change that, even if we had evidence about which one's a better treatment. And again, there are lots of reasons, lots of theoretical good reasons for not using egg for a burn injury.
Yeah, I think I settled it with myself with the fact that I thought that water wasn't available, and so I felt I was going to be and I have been very uncomfortable for the last sort of 8 years, aware of the fact that Nancy Canby Arts are going out and telling people to put water on wounds, and I felt uncomfortable, which is why I chose this as my dissertation project, because I thought, do you know, we're telling these people to use water and they probably don't have any. So it was a real discord for me, and so that was part of the reason why I wanted to really explore this. And actually, I felt a big, huge relief. I mean, yes, it was only this village, so technically I can't take that out of context and say Malawi, but water was readily available. It's there, it's stored, it can be used in an emergency. So I felt a bit of a relief there, actually, that
I think a lot of it may just relate to the general kind of lack of understanding of wounds by the community as a whole, and it doesn't matter if it's water or it's actually not really understanding what it means to have the blister, but what it means for skin to peel off. You know, the fact that actually water's actually not doing any harm, and the kind of is part of a normal part of the burn that will happen.
Yes.
And egg's not going to stop that.
No.
But it's just that kind of the general understanding of health in general, probably, and the lack of understanding of possibly wound care, not just amongst the patients, but it may be the healthcare workers are not entirely clear themselves. I don't know the situation of what kind of healthcare workers were in that village, but it might be, and there's a general, that's even in the UK, there's a general lack of understanding often about wounds and how wounds behave.
Yes.
Yeah. Thank you very much indeed. We've got a okay, I thought we had a question here in Glasgow, but any questions from Kings or suggestions to Emily as to how she's getting on in presenting her mixed method study?
Hi Emily, Naomi here.
Hi. Oh, hi Naomi, how are you?
A long time.
A very long time.
About 9 years ago in Malawi.
Yeah. Gosh,
I'll go back to Malawi next year. Are you going to be there? We'll have to catch up.
It depends. Yes, I might well be.
We've got a question. 1 second.
I just wanted to say, sorry, hi, Anna, MSc student here. I just wanted to say it was really, really interesting the way to actually be a bit bold and go for a mixed method. It was really nice to see the wall kind of complementing the quant findings. So that was really, really nice to see. So thank you.
Thank you. I had never embarked on qualitative research. I got a fabulous qualitative research lecturer that started at the university, and I'm totally sold on it now. I just think every time I see a quantitative study, I think, but we haven't got to the why. We've described it, and we've explained certain things, but why? And so I was advised that a mixed methods were going to be a lot of work, and they didn't generally suggest it for an MPH. And yeah, I'm really glad that I just thought, no, this is my chance to learn it, I guess, with supervision. So I'm really pleased I did it. And yes, and because the integration of the data comes at the end, there was a big risk that actually there might be a discord. So it was a nice relief when there were explanations coming through from the qualitative stuff.
No, I think you've done it really well, and it's a very brave decision to kind of do that mixed methods, because actually I'm sure you've come across this multiple times, that amongst the medical academics, often kind of these mixed methods or quantitative studies are not valued as in this way as quantitative studies, and I think it's partly due to lack of understanding of qualitative studies and the value of them, and I think we do need to do more of it in the type of work we do.
Absolutely.
Okay, thank you very much for your comment. I'm conscious that we are running out of time. Does anyone have any quick questions they want to put to Emily, I'm sure she's happy to be contacted personally afterwards if you have further comments. But anyone really keen to add any further comment or question briefly?
I was just going to say, I mean, I haven't got an answer. It's a really interesting consideration whether to publish both in the same journal article, whether to publish them separately.
Yeah.
I'm doing mixed methods for my PhD and I'm planning to publish them separately. But yours tell a story together.
That's what I feel, yeah.
They seem to work better in one paper.
Yes.
And you'll just have to put a lot of supplementary material and really cut down to the nitty gritty.
Yes, yeah. No, that's helpful. Yeah, I do feel that it needs to be presented together. I think it does complement each other, and yeah, like you say, it tells the story, doesn't it?
Okay.
Thanks.
Thank you very much for that comment.
Thanks, no, that's good.
You're welcome. Listen, I'm really, really grateful for all of you for giving up your evening to listen and to comment and to engage. And we will do this again in the next few months. Thank you again for being with us. Totally unforeseen circumstances of a stapler misfiring deep in the pelvis. Unfortunately made that a bit challenging, but we've had two really high quality presentations, I think. So thanks again and see you soon.
Thanks, everybody.
Thank you.
Bye.
Right.
Thanks, Emily. That's so interesting.
I was going to tell you, I did a master's and I did a mixed method study in Mexico.
Right.
Thanks so much for
And
See you later. Nice to meet you.
my paper was strengthened by check between the quantitative and quantitative.
And I mean, I guess I've just got to. The problem is, there's so much there that I want us to be able to say about it.